Best case ever.
Best case ever.
Yes, this is EM Case's Best Case Ever mini podcast series, and I'm your host, Dr. Anton Hellman. It's my absolute pleasure to welcome my friend, colleague, and amazing EM researcher, Dr. Catherine Varner, to EM Cases. Dr. Varner, welcome to EM Cases, and just tell us a little bit about your professional background.
Thanks, Anton. I'm excited to be here. And I am a clinician scientist at the Schwartz-Reisman Emergency Medicine Institute, also known as SREMI, at Mount Sinai Hospital, where I'm also a practicing emergency physician. And I'm an assistant professor in the Department of Family and Community Medicine at the University of Toronto.
At North York General, where I work, we see dozens of patients every day in their first trimester with belly pain and or bleeding. And there seems to be quite a variation in practice when it comes to how to work these patients up. We covered first trimester bleeds in episode 23, but it's so common and the guidelines have changed a bit since then that I thought it'd be great to have Dr. Varner tell her story of her best case ever of a patient in their first trimester. So, Dr. Varner, let it rip. Let's hear your best case ever.
So this is a case back from my training, and I think it really exemplifies a lot of the pitfalls that we commonly encounter in diagnosing and managing ectopic pregnancy. So at the time, I was working as a trainee at a hospital that did not have gynecology services available. And if we encountered a gynecologic emergency, we were able to transfer fairly quickly to a tertiary care hospital. And it was a busy evening shift, pretty typical of most evening shifts in emergency departments. And we were seeing a lot of patients in hallway beds. And our nurse came to me and asked for an analgesic order for a young woman who was writhing in pain on a stretcher in the hallway. And I went to see the patient. She was 30 years old. She looked really uncomfortable. She was holding her lower abdomen, kind of writhing in discomfort, and described how she had had pain over the last 24 hours that had been escalating. And earlier in the day, she had attended a walk-in clinic where she had a physical exam done and some other testing. And she handed me a note from the physician at the walk-in clinic. And the note described a 30-year-old woman with abdominal pain for 24 hours, and rule out appendicitis was the working diagnosis because the patient had undergone an ultrasound at the walk-in clinic by a radiologist where they could not identify the appendix, but she had a trace free fluid in her right lower quadrant and a negative urine test that only had positive Lukes and trace blood.
A negative urine beta, right?
Yes, negative urine beta. And so on further history, she described this pain as having been ongoing and had gotten significantly worse since the visit this morning and the subsequent ultrasound. And she was previously healthy, had never been pregnant before. She had had no history of sexually transmitted infections. And she said that she was in a monogamous relationship where they intermittently used contraception. Her last menstrual period was about 6 weeks before, but she said she's frequently irregular. She also alluded to the fact that her urine pregnancy test at the walk-in clinic today was negative. And her physical exam, when her vitals were completely normal, and her abdomen was soft but had quite discernible right lower quadrant tenderness, kind of extended through her lower abdomen. And at that point, I ordered some analgesia, which included morphine and Gravol, and as well as routine blood work, which included a serum beta HCG. After receiving morphine, she looked a lot more comfortable, and I went on about seeing my other patients.
So what were you thinking at this point in terms of the likelihood that she had appendicitis versus something else? And what was in your differential at that point?
So certainly appendicitis was one of the highest things on my list. I also thought about pelvic inflammatory disease, despite having no risk factors per se of sexually transmitted infections. She was in a hallway, so at the time I did not do a pelvic exam, and I was just going to wait and see what her further investigations looked like before going forward.
All right, so what did the blood work come back as?
So about an hour later, the nurse who was helping me look after this patient came and said, "Did you know she was pregnant?" And it turned out that her beta HCG was 52, which was quite a surprise to me at the time. And I went back to the bedside to reassess this patient. We also got some of the other blood work back. So her hemoglobin was 115 and her white blood cell count was 13, and the rest of her blood work was completely normal. So I obviously went back to the bedside and looked at this patient now with very different eyes.
I bet. So now you've got a patient with a beta of 52. So now they're pregnant with pain. Still could be appendicitis, but of course, ectopic is now in your differential. Did you do a POCUS at that point?
So we certainly did. So the attending physician I was working with and I did POCUS together. We saw that there was free fluid around her uterus as well as her right ovary. And then she also had a trace amount of free fluid in Morrison's pouch. And it was one of those moments where the whole team looked at each other and felt quite sheepish because we realized that we had initially missed the diagnosis of a ruptured ectopic pregnancy.
All right. So at this point, I bet you got onto the horn with the gynecologist. What happened after that? Did you get the patient straight to the OR or?
So she was transferred quite quickly to the tertiary care hospital. And what was interesting was that even the gynecologist was quite insistent about having a transvaginal ultrasound interpreted by a radiologist because of the distraction of the appendicitis at the original visit. So she did undergo a transvaginal ultrasound quite urgently. It documented she had moderate amount of free fluid in her abdomen and a structure in the right lower quadrant that looked like an ectopic pregnancy that was around 6 centimeters in size. She went straight to the OR from there and had a salpingectomy after seeing an obvious right-sided ruptured ectopic pregnancy. And she had about 1.5 liters of blood in her abdomen. She had a relatively uncomplicated postoperative course and at the end did fine.
All right. So, Dr. Varner, you got this patient who initially everyone thought was appendicitis. It turned out to be ectopic. This is a very common scenario we see in the emergency department. What did you learn from this case?
So I think the first and foremost thing was how easily we can be biased by test results and the opinions of other providers. And certainly when I was seeing this patient initially, I thought she had appendicitis and I fixated on that diagnosis and really didn't even consider the fact that she may have had a ruptured ectopic pregnancy, especially in the context of a negative urine beta HCG.
Right, that's that classic cognitive error of diagnostic momentum, where the referring physician says they think it's appendicitis, and then the nurse says they think it's appendicitis, and then you think it's appendicitis, and then you fail to keep your differential wide. So that's a great learning point. Let's talk a little bit about the pitfalls in the diagnosis of ectopic. What were some of the kind of pitfalls that you learned? You had mentioned the urine beta HCG. Well, let's start with that. What's the pitfall with the urine beta HCG?
I think relying on a urine beta HCG is really inappropriate in any clinical setting where you're excluding ectopic pregnancy in a patient. And there are a couple of reasons why. So the detectable level of a beta HCG for a urine test can be anywhere from 20 to 150. In early pregnancy, these tests can therefore be false negative. These tests are also quite user-dependent, so both in how the sample is interpreted as well as how the sample is collected. And patients can also have a false negative if their urine is very dilute.
All right. So, yeah, if they've been drinking liters of water, then they could certainly have a negative urine beta HCG. So I guess the first pitfall there is relying on a urine beta HCG in early pregnancy. Really, we need to do serum beta HCGs. And when it comes to serum beta HCGs, this patient had a beta HCG of only 52. And traditionally, we've been taught that there's a discriminatory zone of 1,000, that under 1,000, it's very unlikely that someone has an ectopic pregnancy. Yet this patient had a beta HCG of 52. I've even heard about case reports of lower than that. What do we need to know about beta HCGs when it comes to ruling out ectopics?
So the first thing I would say with respect to ruling out ectopics is there really is no discriminatory zone where an ectopic pregnancy is not possible for the beta HCG. And it's in part understanding that patients can present with a ruptured ectopic pregnancy at a variety of different points in the beta-HCG level. So patients' beta-HCGs may be rising, they may be plateauing, or they may be falling. And so patients can have a very low beta-HCG that has been falling over the period prior to rupture. And so there's not a beta-HCG level that you can exclude a ruptured ectopic pregnancy. And what we've seen when looking at patients over the last 7 years in the emergency department of Mount Sinai is that the lowest ruptured ectopic pregnancy beta-HCG level was at 44, and the highest we've seen was around 39,000. So any patient who presents to the emergency department with a detectable serum beta-HCG should still be considered as possibly having a ruptured ectopic pregnancy.
All right, great. So the second pitfall there would be ruling out ectopic pregnancy based on a low beta-HCG level. Really, any beta-HCG level is consistent with an ectopic pregnancy. The other thing I noticed with this patient was that they had no identifiable risk factors for ectopic pregnancy. What does the literature say out there in terms of the value of risk factors in helping you rule in or rule out ectopic pregnancy?
So we know that there are risk factors that are associated with ectopic pregnancy. So in vitro fertilization, smoking, history of pelvic inflammatory disease, any history of a sexually transmitted infection, risk factors that have been identified. However, the majority of patients, so more than 50% of patients who are presenting with ectopic pregnancy will not have any risk factors present in their history. And
wow. The majority of patients won't have any risk factors. That kind of sucks because here we are trying to, change our pretest probability of a patient having an ectopic. It seems like, the risk factors aren't very helpful. Urine beta-HCG certainly isn't helpful. Even the serum beta-HCG doesn't help us that much. Is there anything besides a transvaginal ultrasound that can help us rule in or rule out an ectopic pregnancy?
So, unfortunately, many aspects of the history and physical exam are not going to be helpful in this clinical context. However, we are fortunate to have point-of-care ultrasound available to us, which can help us exclude ectopic pregnancy when we identify an intrauterine pregnancy utilizing POCUS. So, if you have an intrauterine pregnancy that's visualized on a point-of-care ultrasound, your likelihood of having ectopic pregnancy now becomes negligible because an ectopic pregnancy in that scenario is going to be a heterotopic pregnancy. And in patients that are not undergoing assisted reproductive technologies, the rate of heterotopic pregnancy in the general population is around 1 in 50,000.
Wow, so that's really quite rare. The other thing I noticed with this patient was that they had perfectly normal vital signs, despite the fact that they had 1.5 liters of blood in their belly from their ruptured ectopic, which is quite amazing.
Even to the point that when she was going into the operating room, the last documented vital signs were completely normal, despite having 1.5 liters of blood in her abdomen. And I think that speaks to the physiologic reserve in this patient population. They really do well hemodynamically until they've lost a significant amount of blood. And at that point, they become very unstable.
So Dr. Varner, you had mentioned that POCUS can help us rule out an ectopic pregnancy, but it doesn't always help us. That brings us to doing a transvaginal ultrasound done in the radiology department. Which patients need a transvaginal ultrasound and how soon do they need them? I mean, this is a big problem in some centers where there's not 24-hour access to transvaginal ultrasound.
This is a great question and a great topic of discussion. And if you look in the obstetrical literature, the recommendations in this patient population is if you have a patient presenting with first trimester bleeding or abdominal pain, they should be undergoing definitive transvaginal ultrasound assessment to exclude ectopic pregnancy. And the challenge in many centers is that we don't have 24-hour ultrasound availability. And I do think that POCUS can assist us with bridging that gap. But if you have a point-of-care ultrasound assessment done that does not document an intrauterine pregnancy and your patient has pain, vaginal bleeding, setting and a positive beta HCG, they really should be undergoing urgent transvaginal ultrasound assessment to make sure that they don't have an ectopic pregnancy.
Yeah, I mean, given that the risk factors aren't very helpful, that the physical exam isn't very helpful, that the vital signs aren't very helpful, that pretty much any serum beta HCG level, you can still have an ectopic, it makes sense that these patients all need a pretty quick transvaginal ultrasound because many of them will go on to rupture. What about the situation when someone's been put on methotrexate for a stable ectopic and they come back to the emergency department with belly pain? Are those the kind of patients that we need to worry about a ruptured ectopic pregnancy in?
So methotrexate has been extensively studied, both prospectively as well as in the clinical trial setting, and patients can be safely medically managed using methotrexate in certain clinical indications. So these patients generally have a low beta HCG. They don't have a fetal pole or yolk sac identifiable. They are without pain, and they don't have any of the relative contraindications to receiving methotrexate treatment, which is a beta HCG of greater than 5,000, detection of fetal cardiac activity, or an ectopic pregnancy size of greater than 4 centimeters. So in that clinical context, the success rate of methotrexate treatment is around 90%. However, 10% of these patients fail methotrexate treatment, and then a portion of these patients are going to have a ruptured ectopic pregnancy. And so, unfortunately, if a patient is presenting to the emergency department and is on methotrexate and has pain, we still need to consider ruptured ectopic pregnancy as a possibility in these patients and need to work and assess them accordingly. And it's also important to note that even if this patient does not have a ruptured ectopic pregnancy, if they are now experiencing new pain, it's important for their gynecologist to know that the patient has new pain because it may change whether or not the patient continues with the medical management or if they then opt to have elective surgical management of the ectopic pregnancy.
All right. So there's a lot of pitfalls we just unpacked there. One, that ruling out ectopic pregnancy based on a beta HCG level is one of the big pitfalls, that any beta HCG level can be present with an ectopic. The second pitfall would be relying on a urine beta HCG in early pregnancy. We know that urine beta HCGs in early pregnancy are unreliable. There's lots of false negatives. The third pitfall would be assuming low risk of ectopic pregnancy in a patient with no identifiable risk factors. Because the majority, in fact, of ectopic pregnancies discovered do not have any identifiable risk factors. The fourth pitfall would be assuming low risk of ruptured ectopic based on normal vital signs. These patients can bleed out 1 liter, 2 liters into their belly and still maintain those normal vitals. The other pitfall would be forgoing or delaying a transvaginal ultrasound to rule out ectopic based on the history, physical, and beta in really any patient with a first trimester bleed or first trimester belly pain. And then lastly, assuming that a patient taking methotrexate for known ectopic pregnancy presenting with belly pain has a low risk for rupture. They certainly do have a risk for rupture when they are on methotrexate, so you need to rule that out when they come back to your emergency department with pain. Well, thank you so much, Dr. Varner. It was a pleasure having you on EM Cases, and best of luck with all your future research when it comes to ectopic pregnancies.
Thanks so much, Anton. It's been a pleasure.